Hello and welcome everyone to the last plenary session of the day and the last plenary session of the conference. Thank you very much for being here and resisting until the last. So you have seen that we have had a theme of the day for all the plenary sessions. Today it was the same. The theme for today was equity and health. The session in the morning was talking about inequities, it was talking about stigma, it was talking about how we can pass our message, the information we have to our communities. We were talking about this fantastic word I heard, this info epidemics. Now in the afternoon, we are going to talk about how we can actually transform our message, our numbers, our facts, into a message that can resonate in our communities, a message that our populations can relate with. And for this, Piotr, the chair of this scientific committee, and my colleague here chairing, will introduce our speakers.
Thank you very much. It's my great pleasure to introduce our distinguished speakers. We will hear from Grazia Caleo. She used to be a public health consultant to Médecins Sans Frontières, but now she works as an independent scholar, and her focus is trying to link the human rights to the broader public health. And we will also have Elburg van Boetzelaer. She is working now as an epidemiologist advisor to the Médecins Sans Frontières, and she has a lot of experience with translating data into stories, narratives, and changing people's behaviors that way.
Yeah, and we will have some time for questions, and we will have some debate among us. But meanwhile, I will invite Grazia to start with the first presentation.
So, good afternoon. This week you saw a lot of numbers, and this session you will not see any numbers. So, because we want to work together to humanize public health to address health inequities. So, we thought to frame this session looking at two elements, the tangible and the intangible elements. Now, we are very familiar and comfortable with the tangible, meaning data, surveillance data, vaccination data, or methodology like a case control study. But where we are less good at, and as well less comfortable, is basically the intangible, meaning storytelling, art-based methodology, community narrative. So we know that numbers as a public health are important for us because they provide rigor and structure for public health action. But numbers, they don't give us context, and they don't give us the meaning behind those numbers. So we thought that it's important that those two reality, the reality of the tangible and the reality of the intangible, they need to meet to create a space for public health to be a space of that is inclusive, that is equitable, that as well is a space that is offers solidarity, meaning that we recognize and we stand for others and with others. So we will first show a couple of video, but as well some tangible example on how number can enter in dialogue with the intangible to create this space that can improve public health and humanize public health. So this is a video, a short video of a big project. It's a project that I am leading of public health for children and children for public health, and basically it's a children's book that I wrote on Ebola. So you will see a short video, and then I will take you in this journey on how this book has been created. I think, yeah. So, my journey to, let's say, transition from the tangible, so be a medical doctor, an epidemiologist, to then create a children's book has not been a linear journey, actually very complex. First, starting as an epidemiologist, responding to multiple outbreaks in different countries, then embarking in a PhD on Ebola, and then creating a children's book. So why I decided to write a children's book without myself even having children? So first, because in the field and as a practitioner, I witnessed the fracture between public health and community, a fracture that has created violence, has contributed to division. For example, we can think about Liberia riots against the quarantine measure, or more recently in DRC, attack to Ebola center, or killing, for example, colleague working during Ebola. So, in my experience, I saw fear, stigma, and violence to travel much faster than virus. And this fracture between public health and community doesn't stem from the vacuum, but actually is a fracture that is grounded into epistemic injustice, meaning that the lived experience and the knowledge of the community with whom we should work with is often not represented in public health narrative or practice. Not last, during my experience as a doctor in the field, I saw a huge toll of death among children, among older people, and their stories were not represented in the public health domain or evidence. Not last, when often I was designing a public health intervention, I didn't have myself human rights lens to make design intervention that could take into account children and human rights. So I came to the conclusion that neither evidence or practice can tell the full story. So this journey basically is a journey that aims to create a new path and to bridge the tangible, the data, with the intangible, the story of the people. So the book draws on lived experience, research, and as well historical events to create something that is authentic. I used the simple poetic language and illustration that can communicate deeper meaning and offer a public health narrative to reduce stigma to Ebola survivor and foster emotional recovery and community solidarity. So in the book, I brought a lot of what I learned during my PhD into the book. So the village in the book is a real village that participated to a mixed method study that informed us which public health measure we were implementing that actually were contributing to death and as well to transmission pattern. As well, in the book, I integrated the outbreak response activity that we were conducting in collaboration with Okada driver to map out area of Ebola transmission with the attempt to acknowledge the role of community in public health to save life, and as well to resist to simplify the top-down narrative that in a way they dismiss the role of community in their role as frontliners. So I turned some epidemiological practice in what I think is act of courage. So the grandmother, that is a traditional healer, she is brave to acknowledge that she has never seen a disease like that. And she explained in very simple words, mode of transmission, that often as epidemiologists we struggle to communicate. I've never seen a disease like this, that when you touch, you die, you close your eyes. On the other hand, the child is brave. She understands that she needs to look for help, and she looks for the contact tracer. In the book, there is a continuous dialogue between the real but as well the symbolic. The real are water sanitation measures that they are essential to control the outbreak, and the symbolic is basically the motif of the tree that represent wisdom, but at the same time represent somebody that is witnessing the unfolding and the tragedy of the outbreak. So in the book as well, a lot of unnoticed daily gesture of care that they shape the outbreak, they actually are valued and not dismissed, like preparing every day chlorine multiple times or feeding patients, for example, when we didn't have either vaccine or treatment. I also included in this project colonial elements. So the tree is a real tree, and there are some legends around this tree in Sierra Leone, that under this tree the slave trade was occurring. So in the book the tree represents ancestral trauma, but as well ancestral wisdom that we share with nature. So in conclusion, this project brings together the tangible and the intangible, showing that outbreaks are shaped by what we can measure, but as well what we can feel and remember. That public health is not only counted, but is most of the time experienced. I hope that this project encourages reflection, hope, and empathy, to build solidarity as a core, inclusive and equitable public health. Thank you.
Now, I would like to invite Elburg to give her presentation, and then after that we'll have the discussion. Elburg, please, the floor is yours.
Thank you. So Grazia has just talked quite a bit about children. I will talk a bit about older people. I recently completed my PhD on the healthcare needs of older people in complex humanitarian crises. And really trying to unite these tangible elements and intangible elements. So as we all know, we're undergoing a global demographic shift. In 2050, 1 in 5 people will be over 60, of which 80% are going to be living in low and middle income countries, where we know that humanitarian crises hit hardest. We also know that humanitarian crises are going to become more complex, more protracted, also because of the climate change. And that older people are disproportionately affected by humanitarian crises, for example, because of pre-existing health conditions, limited mobility, cognitive decline. We also know that older people often play central roles in their community as community connectors, as the memory, the collective memory of their community, as first responders to humanitarian crises, but yet they remain overlooked in humanitarian preparedness and response. And this is due to ageism at different levels. So for the methods that we employed, we really undertook this tangible approach first. So we looked at the analysis of routinely collected data at inpatient departments, mental health services, and sexual violence services at MSF. And we tried to look at intersectionality. So we looked at age, we looked at sex, we looked at displacement status, disability status, and region, and how this affects the healthcare needs of older people. And then we had very tangible outputs, right? We had peer-reviewed publications, we organized a symposium, we had a series of webinars, it's still ongoing. But it also led us to reflect a bit on the intangible. By reporting on all this quantitative data, what are we actually missing? Are we missing the stories of older people themselves? And also the way that we collect data, these classical methods of data collection, are they actually inclusive? So in MSF, for example, we do very often household surveys where we speak with the heads of household. But does the head of the household necessarily know about the healthcare needs of the older people residing in their household? And when we organize focus groups, do we actually make sure that people can reach the place where these focus groups are held? Can we make sure that an older person can actually reach the central point? And all of this led to reflections around epistemic injustice, what Grazia has just mentioned as well. Is the knowledge of older people actually being considered and also being quite directive in the responses that we do? Answer is probably no. So as next steps, we're considering more participatory methods, as was also mentioned this morning, and also, for example, arts-based methods, which Grazia has just, presented, but also trying to really think about inclusive methods of data collection that might be a bit out of the box, might be a bit creative, but might actually be much more inclusive. So for the work that we've done so far, we tried to move a little bit more to this intangible and include stories. And we did this through a now traveling photo exhibition of older people who have lived through humanitarian crises and their testimonies. And we also made a short film trying to really put a face to the data that we presented through all of these peer-reviewed publications. And I would like to show the film.
My name is Monica. I am 70 years old and live in Pakistan. I want to share my story. I am a farmer, married to my husband Mohammed. I was injured when I slipped in the mud during the floods. We lost our crops and livestock. We left our home in panic, carrying terrible memories. Now we live in tents in front of our damaged house. Before the floods, we were busy farming and lived a decent life. Today, everything is different and difficult. We face food shortages, no medical supplies, and no clean water, as the village pipes were destroyed. I have hepatitis from drinking muddy water. No one is helping us. I have 3 sons and 6 grandchildren. They cannot go to school. My husband suffers from anxiety. We are depressed and worried about our losses. My story is not unique. Around the world, millions of older people face crises. By 2050, 1 in 5 people will be over 60, the majority living in low and middle income countries, where humanitarian crises hit hardest. Crises caused by conflict, discrimination, disasters, food insecurity, and disease outbreaks will only grow more complex and protracted in the years to come. And in this crisis, older people are disproportionately affected, yet too often overlooked. Among us, some are even more invisible. Older people with disabilities, older people who identify as LGBTQ, older people with mental health symptoms, older women, older people with infectious diseases such as cholera or Ebola, older people with cancer, older people with sexual and reproductive health needs, older survivors of sexual violence and intimate partner violence, and many, many more. Evidence shows that in humanitarian contexts, older people carry a double disease burden, more often admitted at hospitals for both chronic illnesses and infections. Older women face higher risks, including malaria, diabetes, respiratory tract infections, and high blood pressure. Many older people experience anxiety, physical complaints, and mood-related symptoms. They also face challenges linked to aging, for which mental health services are often not equipped. Displacement, violence, and trauma intensify these struggles, especially for older women. Older adults experience distinct patterns of sexual violence. Assaults against older women are done by multiple unknown armed assailants during survival tasks, such as looking for food or wood. Sexual violence against older men is rarely acknowledged. Disability and displacement make older people even more vulnerable to repeated violence. Why are our needs, experiences, and voices still overlooked? We are overlooked because of ages, because services are not designed with and for us, because our rights are still not protected by a UN convention. Yet, we are not only vulnerable, we are caregivers, we are leaders, we hold memories of past disasters and wisdom for the future. Some call us the living library of the community. Still, we remain invisible. Only with an intergenerational humanitarian response, one that recognizes us and fosters our dignity and rights, can we truly prevent and address crisis. Participate is the future.
It's a bit abrupt. Okay, it goes on afterwards. But just for the purpose of time. So what we, in this session, Grazia and I really try to illustrate is to think about the tangible outcomes that we all know as epidemiologists, but also think about intangible ways of communicating a story. And we would like to invite all of you to reflect a bit on your daily work and think about how these intangible elements could enrich the work that you're already doing. And maybe, I don't know, tonight on the way to the airport, or tomorrow when you're having dinner, exchange with your colleagues, think about the inspiration and how you might consider more intangible elements in your daily work. Thanks.
Thank you. Thank you, Elburg. And I think these were two fantastic examples of the message we want to convey. So we have numbers, and we have powerful numbers. We have powerful confidence intervals, as Grazia would like to say. But we have stories to tell. Here I'm not talking about storytelling as in a workshop. I'm really talking about stories that we have to tell. We need to find a way of convey our message beyond the numbers. And these were two powerful examples of basing on the facts, the real facts, not forgetting the science, based on articles, how can we transform that message into something that people would relate with? And I was thinking, myself, as you were saying, think and reflect. I was thinking of my own experience. And for those who don't know me, I'm basically a trainer for the last years of my career with EPIED and FETP, the UK FETP. What I really like to do is training material. That's what I really like to do, write down training material. That's the story I have to tell. If I was not an epidemiologist, if I had not worked on epidemiology, I would be totally unable to write what I write. So this is, let's say, I would say, a humble example of what we can do, transform the things that we do in something that would reach our target population, in my case, the poor fellows. So, And I think the same applies for everyone, that we can reflect on how we can transform our message. That would be my bomb. And I think that was the message, wasn't it?
What do you think was the message?
Well, I think it's very good that we talk about this, and there is a lot of appreciation of this, what we see in the chat. Thank you very much. Thank you, Grazia, for such a beautiful work. Your words explained what I have felt many times on the importance of the intangible and not being able to report it or share it as I would wish. May our embrace be of the widest possible. And the appreciation goes to the point that somebody says, I am enjoying this, I hope to be a speaker one day. Well, talk to us, please, we are very inclusive. We'll definitely consider.
Yeah, there's a lot of appreciation and some reflection here on some ideas that I also think are coming from the theme of the day, this equity and thinking about our populations, like not forgetting who we are talking to. And there is a question here I wanted to comment, actually, moving a bit for the presentations. There is a question here about whether the people from the village were included in the book writing.
So the people in the village, they participated in the mixed method study, and then before the interpretation as well of the data, we went back in the village to share with them their own story. And what they told us is that they thanked us because they thought that there was a huge trauma that the village experienced. They had a lot of death and prolonged the transmission. And for them to hear back their story and the interpretation of their story really helped as well to reconcile with some, of the activity that the Minister of Health, MSF, and all the other responders, they have actually contributed to create more suffering at the end of the day. So yeah, was included at different stage of the project. I think my main message is that I couldn't write a children's book without being first in contact with patients as a doctor, feeding patients, especially in a moment where we didn't have any vaccination or any treatment. So for me, the contact with the patients helped me to realize that was not just important for me to do an epidemic curve or a mapping, but for me in that moment it was important to be with the patients. And then starting from there to understand the transmission. So I think sometimes we needed to go back to the basic, to what motivates us, to what has helped us to make choice in life, to then go forward.
Yeah. And going back to the basis, this makes me think something as basic as the data collection. And also thinking of which is the data we are collecting from our populations, in the sense that they represent what the population is without blaming anyone, without looking for any stigma. That's something that we have discussed about these days as well. How we want to convey our message, but understanding the populations we are talking to without blaming them from what is going on, right? It's part of the Ebola as well, the experience, and also it's part of the experience with the elder in these settings. Yeah.
Yeah, let's get as much knowledge from the two experts as possible here, because we have to go beyond the pure numbers. We had it at one of the, I think in the morning session, that somebody said they had to explain to their neighbor who was a medical doctor what they do, and they said, I'm an epidemiologist, and the doctor said, so you count cases. And that's how we are seen often, and I think we have to go beyond that to breach this stereotype, and this is great. Actually, we have to include stories, narratives, emotional messages. We tried during the pandemic, and because this changes behavior, data don't change behavior per se.
Yeah, and it's also just really valuing the lived experience of the people that we work with, right? And not just seeing them as cases or as these abstract communities. No, they're individuals, they're persons, they're you and I, and everyone deserves that respect to be able to tell their story in a way that it feels okay for them and that can go through an interview or a survey, but it might also be a very different making a word of art to tell your experience during a certain phase. Or yeah, I think we really have to start thinking more creatively and start from the point where I would also like to make a work of art about my experience rather than having a focus group. So it also starts there.
Yeah. And there are different ways. I mean, we have the book, we have a video. There was a parallel session on a special event. I should know how to call these things. But there was today another session, and it was about a podcast. So there are ways of making our message reach our populations. I would insist in that. Not forgetting what is actually the profile of the individuals we are discussing or we are talking to.
Yeah.
Yeah. Yeah.
We have another question. Again, compliments. It's very nice to see different ways of talking about public health. But there's a question, could you develop a bit more on who were the target audiences for the book? And another one, any plans on translation or cultural adaptation? For example, converting it into songs, other materials. Any plans?
So the target audience is everybody. So the minimum age for children, I did a lot of workshop in the last months with many children in the peripheral area of London where I live. And there were children as young as 4, as 5, really much enjoying the story and the co-creation of other story. So let's say from 7 to up. So there is no limit. And in terms of translation, we are considering to translate it in languages where Ebola outbreaks are occurring, so DRC and other contexts where we experience outbreaks. I want just to go back to the previous conversation. I think what hampers public health to be inclusive is our language. So the epidemiological language is extremely difficult for everybody. So it's difficult to explain what is an incubation period to even our relative or colleague. So I think there is a work that needs to be done on how we can simplify public health language to be more inclusive. And I didn't hear much on those days on the simplification of a language that is accessible, because if people don't understand us, it's very difficult to bridge any fracture.
Yeah, and it's really nice to see from the message and the comment from the online audience that everyone is agreeing on this need of communicating things in plain terms. I would dare to ask, is there anyone here in the audience that would like to ask us a question as well, or share an experience from their lives?
Please feel free to share with us your experiences. Elburg invited everyone to think about what inspired you, also during the other sessions at Escaide. Escaide is about inspiring each other and then taking the inspiration. When you go back, we are coming closer to the closing session now. So please write it down somewhere what inspired you, but also if you want to share, please go ahead. I think there is a question or comment there.
Yeah, and thank you very much for this important topic, and I really agree that we also need to communicate in other ways. But I just wanted to raise that sometimes it's also a challenge for us with the personal stories. That's what we experience when we see those who have had side effects to vaccinations. We experienced that in Denmark during the HPV crisis, where there were television programs about those who had side effects or possible side effects to vaccinations. So I think sometimes it's difficult to navigate in this field to find out how to balance numbers compared to these personal stories.
Yes, difficult, but we cannot surrender. This is the reality, because we are seeing how much misinformation, fake information, and how public health is polarized. So it's really our role to find any meaning, to be transparent, to admit what we don't know about, during the COVID, we haven't been necessarily all the time transparent of what we didn't know on what, how we could support the community. And this happened in many, many public health events. So I think there is a role for us to resist in a positive way, to look for other, to recognize art as a science, to reach out other, discipline and work together. We should be more inclusive in the way that I didn't know how to write a children's book. I don't know how to draw at all. But now at home I have a lot of colors. In the sense that we have to go out of our comfort zone and, and resist, because our job is too important to give up. And others will not give up.
Thank you. Going back to the question from the audience, there's one from Elburg. For Elburg, it's about that, going back to the video. What was specifically the target for your video, and whether there was any impact that you could see after this was made available?
I think the target audience is everyone who will watch, honestly, because I think older people, are just absolutely overlooked in humanitarian crises. We focus on kids, we focus on women. I'm not saying that we shouldn't, but older people are also a vulnerable population that is off the radar, I would say. So I think anyone who will watch it should watch it and take it on board. So we're really trying to promote the video as well. And we haven't measured the impact, but from the feedback I've anecdotally received is that it's more digestible and it's more personable for people, I think, because they hear the story of Maluka, the testimony, and it's real. We didn't make it up, but I think it speaks more to people. Yeah.
And I think somehow this links with the comment we had from the audience, because there are stories that are powerful stories that we cannot neglect or deny. But we also have powerful stories. And we have many powerful stories that can go together with these others that may convey the different message that we want. We have powerful stories, but we are not that used to work in this way. We are more used to the numbers. Maybe this is a session to inspire everyone to go beyond the numbers. I like numbers, but anyway.
Yeah, but I think the argument's not to forget the numbers. Eh? Yeah. We still need the numbers.
No.
Just complementary.
Complement the numbers. Okay. Any other comment from the audience?
In the meantime, while people are thinking about it, could you tell us a little more about how you encourage the collaboration of people who primarily count cases, and because it's still what you do is a bit non-traditional, using art or narrative stories, books. How do you encourage the collaboration, or what experiences do you have in collaboration with other public health specialties?
Do you want to go about the illustration? Well, I think, to be honest, that will be good if for example, in the curriculum of EPIET, we open up to other discipline, to social science, to art-based method, to make sure that we give value and space and understanding as well their own language, because there is a lot that we can learn from social science. So, for example, understanding our positionality, the power that often we hold, reflecting, in our practice. So there is an opportunity, I guess, now to open the curriculum to other disciplines and learn from each other.
Thank you. We have a question there. Vivian, please.
Yes, Vivian Bremer, Robert Koch Institute. Thank you very much for these two inspiring presentations. I really think wonderful. Grazia, you alluded to the pandemic, so I would like to ask both of you, if we would have used these kind of methods and these kind of narratives also for the pandemic, do you think it would have changed some things in terms of trust in the communities?
Well, it's difficult to say it in retrospect what we didn't or we should have. I guess what I am learning by doing a workshop with the children is that they love science, you know? So they have an appetite to understand. So I guess it's to open up public health to children, because the children are our ambassador into the household. Many places where I was working during a cholera outbreak, measles outbreak, polio outbreak, actually, I always rely on children to take me to the household, to introduce me to the household, to found a language. So I think we should, acknowledge that children have a right to participate as a part of the, Children's Rights Convention, and be inclusive, because they are at the front line of all the outbreaks. Measles outbreak, children, they pay the toll. But how many times we include them into public health?
Actually, we have a child in the front row.
Yeah, so I was really amazed.
She could be a good ambassador, I think, for us. Elburg, anything?
Yeah, really hard to say if it would have changed the course of COVID-19, but I think in principle, if we look into our own hearts, we realize, I think, pretty quickly that storytelling always resonates, and I think that's just what it is, honestly.
I'm sorry, we had to coordinate a bit.
Yeah.
Okay, we are coming closer to the end of the session, so it's very difficult to summarize, I think. So maybe, Alicia, you start, and I think...
Sorry, I must admit, I was checking where there were last comments, and I didn't hear what you said.
Well, I think we talked a lot about thinking out of the box, and thinking about how to translate what we do, all the data that we collect, the phylogenetic trees and the odds ratios and relative risks and confidence intervals and penalized logistic regression into something that would actually, that people would understand and that would change their behaviors. We saw during the pandemic, we had a lot of data, very good results about vaccine effectiveness, safety, and still the adherence to all this was quite suboptimal. And I think what you showed can actually help us bridge this gap.
Exactly. Yeah. And for me, it's been inspirational. Thank you very much.
Thank you.
Thank you.
There you go.